Okay, great. So nice to have many of you guys back. And today we're really going to be focusing on really trying to think about really special considerations in certain populations of people that you are likely to encounter that are infected with Hep B or whose serologies suggest that they could be at risk for Hep B reactivation. So with that, we're going to get started. So we're still building on our case from the very first session. This is Yuen Lee. She's 28 years of age, and she's now pregnant. She's 32 weeks pregnant. As you will recall, she was born in the United States, but her parents were born in Taiwan and moved to the United States 2 years before her birth here. Yuen was screened for hepatitis B as part of routine prenatal screening, and her test results are shown here. So the screening tests, as we recall, include hepatitis B surface antigen, hepatitis B surface antibody, and hepatitis B core antibody. Of those tests, both the surface antigen and the core antibody came back positive, so we know that she's got chronic hepatitis B. And then this prompted us to check some additional serologies, which included the core IgM, which was negative, so that indicated this was not acute hepatitis B infection. Her E antigen was positive, E antibody was negative, and now we have some additional information with her Hep B DNA viral load count being 1.1 million IUs per ml, and her liver enzyme test, the ALT, came back at 18. So the question becomes, now what do we do? So we're going to talk at the beginning here a little bit about hepatitis B and pregnancy. So we know that during pregnancy, pregnancy is a very immune, forgiving, different time, if you will, where the immune system is really modified to tolerate the fetus and prevent fetal rejection. So immune priming is known to occur mainly through macrophage activation of CD4 and CD8 T cells, not really via B cells. And CXCL3 expression in liver macrophages is ineffective at birth and becomes competent as one becomes older to prevent any problems related to rejection. This could be a potential mechanism for the inverse relation observed with age-dependent clearance of persistence of hepatitis B. So remember in the very first talk, we talked a little bit about the age at which you acquire the infection really determining the risk of developing chronic infection versus spontaneous clearance. And so really the hallmark of how we describe this to patients and to healthcare professionals is that in that infant stage at the time of birth, which is when hepatitis B is most likely to be transmitted if it's mother to child, the immune system isn't fully developed for the newborn, and therefore your risk of developing chronic infection is very high. It's 90% or higher. So vertical transmission can happen via germ cells through transplacental intrauterine routes and then perinatal at the time of delivery. Now, transmission can less commonly happen during gestation, where the E antigen passes through the placenta. And we'll talk a little bit about what puts people at higher risk for mother-to-child transition, but certainly being E antigen positive increases that risk because of this transmission risk during gestation. That's what we would really consider intrauterine. Transmission at the time of delivery, which really accounts for more than 60–70% of cases, is where E antigen and or surface antigen get transmitted through blood exposure at the time of delivery. And then very, less commonly, particularly here in the United States, but higher in other countries where the endemicity rate is much higher, transmission can still occur after delivery. And we'll talk a little bit today about what measures from a public health standpoint we've put in place to try to really minimize the risk of transmission during delivery and transmission after delivery. There are immunoprophylaxis measures that we now have in place in countries like the United States for hepatitis B infected mothers to provide to the newborns after they are born. All right, so it's really important anytime you see somebody who's pregnant that we offer hepatitis B screening to all pregnant women. Screening for Hep B surface antigen at a minimum is recommended to be done as early as possible. So there's no reason to wait until the third trimester or the second trimester, but rather really on the first time that you're meeting a woman that's pregnant, part of your management plan for this patient should be to screen them for hepatitis B with Hep B surface antigen. This is in large part done by our OBGYN physicians who are often on the front lines of seeing these patients, or family practitioners, and sometimes even other primary care-based settings. You might be the first time you're running the pregnancy test and diagnosing and letting somebody know that they're pregnant if they don't already know. And so for all infected women for hepatitis B, it's really important to assess liver function and liver fibrosis as early as possible using blood work, ultrasound, and some of the non-invasive markers of fibrosis that we've discussed in some of the earlier talks. The one thing I will say here is that here in the United States, the FibroScan test, which is that transient elastography test that you can do in the office if you have it available to you, is actually not approved to be used in pregnant women. And the reason for this is that there haven't really actually been large-scale studies done in women who are pregnant to determine safety. As you will recall, transient elastography uses a shear wave, a sound-based wave, to try to measure liver stiffness. So in theory, it's not likely to do much in the way of damage to the pregnant woman or the fetus, but again, because it's not studied, it does not have approval to be used in pregnant women. As part of your workup, as we have talked about in the last 2 sessions, it's important to kind of really know the status of the hepatitis B by checking their serum ALT, e antigen status, your Hep B DNA, which is particularly very important, these tests to make decisions towards the third trimester to determine the need for antiviral therapy. And we'll talk in more detail about what algorithms we use to determine who needs treatment and who does not need treatment. And it's really important that we monitor women after they deliver with at least an ALT and Hep B DNA, not only during their third trimester, but up to 6 months postpartum. This is a time period in which women can actually have hepatic flares where they can either be symptomatic or asymptomatic, where you can see a dramatic rise in the ALT, AST, and some of the other liver tests. So for up to 6 months after you deliver the baby, it's recommended to do some monitoring of the ALT and the Hep B DNA. All right, so in general, we try to, in Hep B infected women, really minimize procedures that might put women at higher risk to transmit the virus to their baby. Some of the older studies actually showed that amniocentesis might confer a higher risk in moms who have a very high Hep B viral load. The more recent studies have shown that some of this data is a little bit discordant, so the strength of the data behind some of these early data has been in question. So it's not an absolute contraindication. But generally, we counsel women to try to avoid as many invasive procedures as possible. There have been studies looking at the mode of delivery. Well, some of the earlier studies showed that C-section is better than vaginal delivery. We actually don't routinely recommend C-section over vaginal delivery across the board for all Hep B infected women. Hep B DNA is found in over 50% of vaginal secretions in pregnant women. The maternal mother-to-child transmission rate, that's what MTCT stands for, in some of the earlier studies showed a higher rate of transmission with vaginal versus 0% with C-section. And in the case of an urgent C-section, it really doesn't seem to have any effect with respect to risk of transmission. So what can we do to help protect the newborn baby at the time of delivery to minimize their risk of transmission? Well, we start by really getting a sense of what the mom's status is with respect to their e antigen. And this is really important because the e antigen presence really confers a higher risk for transmission from the mom to child at the time of birth, in which we know that the vast majority of newborns who acquire the infection at that time will go on to develop chronic infection. And in women who do not have E antigen, that risk is markedly reduced in terms of the risk of mother-to-child transmission. There are two main ways that we can help try to reduce dramatically the risk of transmission of this infection from mother to child, and that's through the administration of hepatitis B immunoglobulin and providing the newborn with a hepatitis B vaccine. And it's recommended that this vaccine and immunoglobulin are both given to the baby of a mom who's infected within under 12 hours after their time of birth. And this really offers your best chance at trying to not have mother-to-child transmission of this infection occur. So you see here, even in those infants that you provide a vaccine and Hep B immunoglobulin within 12 hours, in the E antigen positive mothers, there's still up to 10 to 15% risk of transmitting the virus from mom to baby at birth. So you can kind of really tell based on the information in this table that E antigen status of the mother and the mom having an E antigen presence really confers a much greater risk of mother-to-child transmission. And that risk still is present with the best things that we can give to the newborn to try to reduce that risk. So there's still a 10 to 15% risk of transmitting the virus between mom and newborn with the Hep B vaccine and Hep B immunoglobulin. But you can see it dramatically reduces it from more than 90% to 10 to 15%. So really important, measure that we can provide the newborns at birth if we know the mom's status appropriately. All right. So what do we do for the mom in terms of antiviral treatment, or the woman who's pregnant, really? So if the Hep B DNA viral load is at a level of greater than 8 logs copies per ml, this is associated with the highest rate of perinatal transmission. So they've done many studies now to date that looked at women who had a viral load, above 8 logs per copy versus those who had less than 8 logs per copy. And what we find is that in the women that have a higher viral load, there's a higher risk of transmission from mother to child at birth, for 15% versus 9%. Now, the transmission rate can be significantly reduced, can be present in the range of 3.2% to 6.7%, even when Hep B DNA is in a lower amount. So sorry, let's go back through these 2 points just to make sure I'm being very clear. Hep B DNA greater than 8 logs per copies per ml confers a risk anywhere between 9 to 15%. In women who have a lower viral load, but that viral load is still in the 6 to 8 logs copies per ml range, you can still have a close to 3 to 7% risk of transmission. The antiviral agents that are considered first line and safe during pregnancy are lamivudine, talbivudine, and tenofovir. Tenofovir alafenamide, TAF, the newer prodrug that was approved in November of 2017, is not yet considered safe, mostly because we don't have a lot of data built around it. As you guys are probably aware as providers, the FDA used to give pregnancy classifications for these medications. About 3 years ago, the FDA stopped doing those letter classifications of A, B, C, D, E, F, and X. And so what they now include in the package inserts are descriptives of what studies have been done, if they've been done in animal, human models, and try to give you some safety information. But based on the AASLD guidelines, as well as other guidelines, we know that the safest antiviral treatments include lamivudine, talbivudine, and tenofovir. So out of those 3, we talked last week about what's our first line agents. Our first line agent typically is tenofovir because of the risk of resistance with lamivudine and talbivudine. So remember, lamivudine and talbivudine are not first line agents for Hep B treatment in general, but they're transient use during pregnancy in somebody who needs long-term antiviral treatment could pose issues with resistance in the future. So it's something to keep in mind when you're doing the workup for a Hep B infected woman, that if they're already meeting Hep B guidelines for antiviral treatment independent of pregnancy, you really want to avoid lamivudine and telbuvudine. Now, if they do not meet Hep B guidelines independent of pregnancy, you could still consider lamivudine and telbuvudine in the short-lived world of pregnancy. But to try to really avoid this issue of resistance in the future, most providers now are just giving tenofovir since they don't have to think about whether or not the status of the woman is going to change over time and they're risking resistance. All right, so really tenofovir is preferred in mothers. And again, that Hep B DNA viral load greater than 200,000, sorry, there should be an extra zero here, IUs per ml, is really a transition point that confers higher risk of mother-to-child transmission. And therapy is effective even if resistance to lamivudine and telbuvudine exists. So if you're practicing in a setting in which you don't have access to tenofovir, lamivudine and telbuvudine is okay at trying to reduce the viral load to reduce the risk of mother-to-child transmission. Fetal exposure to drugs in the first trimester generally can theoretically cause mitochondrial toxicity and potential risk for fetal organogenesis. So it's very important to just keep that in mind about all medications, including some antiviral medications to hepatitis B. That's why it's recommended that the ideal timing is between gestational weeks 30 and 32. So really in the third trimester is when we think about timing for starting antiviral treatment. Now, mothers with cirrhosis should initiate antiviral therapy as early as possible. So that's the one caveat to this 30 to 32 week timing in pregnancy. And that's just really generally to avoid flares, try to really keep things quiet with the virus in the liver, and not risk decompensation, which can lead to poor maternal fetal outcomes. So cirrhotics are the only exception to this. So if you have a cirrhotic woman who becomes pregnant and they have hepatitis B infection, we're typically starting antiviral treatment as early as possible. All right, so so someone asked a question, need conversions between copies to ml to IUs per ml. So it's usually a 2-log transition. So we can talk about that a little bit at the end, Jen. All right, so what do we do for women in terms of postpartum management? So it's important to understand that rapid hormone-driven immunological changes are responsible for flares postpartum. So as I mentioned at the beginning, what you can have is a dramatic rise. Sometimes it's symptomatic, sometimes it's asymptomatic, which is why we recommend to monitor the ALT and Hep B DNA levels for up to 6 months postpartum. Breastfeeding does not increase the risk of Hep B transmission, so we actually do not discourage women from breastfeeding. Breastfeeding is a recommended practice to help confer general good immune properties from mom's breast milk and mom's immunoglobulins to the infant. The only exception to breastfeeding, when the circumstances in which we do not encourage breastfeeding, is if there's overt blood in the breast milk or very severe mastitis or skin breakdown with bleeding that's obvious around a chapped nipple. But generally, breastfeeding does not increase your risk of Hep B transmission. Mothers on treatment can choose not to breastfeed, as medication can be secreted in small doses in the milk. And I'll talk a little bit about the timing for when we recommend to stop treatment, which is here. So Hep B infected pregnant women who are not on antiviral therapy, as well as those who stop antiviral treatment at or early after delivery, should be monitored closely for up to 6 months after delivery for hepatitis flares and seroconversion. Long-term follow-up should be continued to assess the need for future therapy. So it's not uncommon that the very first time a woman's getting diagnosed with Hep B is in her childbearing years, because she, as part of her pregnancy workups, gets screened for hepatitis B. And so it's really important from the family practitioner standpoint or the OB/GYN standpoint, or really any physician who's doing that test, that you keep in mind that you want to refer this person for optimal Hep B management. They're in different settings. Many of the OB doctors are doing Hep B management based on the algorithms for who should be initiated on treatment and when. Typically cirrhotics, or if the comfort level of the OB provider around Hep B is not as great, they will send them to a hepatologist or a gastroenterologist for further evaluation or consultation to make sure that they can co-manage the patient together and make decisions about whether or not antiviral therapy are needed. So very important after delivery not to forget that this woman still has hepatitis B infection and needs to have appropriate follow-up and management. All right, so this is actually taken from the CDC. The resources included the URL at the bottom here. They've created some nice handy tools and infographics and algorithms for how to really manage women who are infected with Hep B and when you are finding out that they're infected for Hep B. So a lot of women do not get screened, unfortunately, and do not receive sometimes even any prenatal care until the time when they present for delivery. So the question is, how do we manage the knowledge of the hepatitis B surface antigen test result in terms of the timing of when it's available? So for women who present at the very first time is the time of which they're delivering, which again, we're hoping to see women earlier in their pregnancy, obviously, to optimize their management generally. But you would provide screening for hepatitis B surface antigen. If that was positive, it's important that that is recorded, documented, a part of the woman's medical record, as well as the infant's hospital record that the mom was somebody infected with hepatitis B. And it's really important at the time of screening that if that surface antigen test, which typically comes back pretty quick in most settings, to alert the nursery to make sure that hepatitis B vaccine and HBV immunoglobulin can be administered within the first 12 hours of birth. I can't stress this enough. I think what happens a lot of times is that Hep B vaccine and immunoglobulin is administered prior to discharge from the hospital, but really the optimal timing is within 12 hours of birth. And it's recommended that they're given in separate limbs, and to also make sure that your pediatric provider who's going to be helping to co-manage the newborn is aware of the mom's hepatitis B status. Hepatitis B in the United States, in most cities and states, the surface antigen is reportable to your local public health department. If you're part of a big hospital, usually the lab takes care of the reporting, and to report results in an immunization registry for the newborn in particular. So if your surface antigen comes back negative at the time of delivery and you're still concerned, how am I certain this patient's not in an acute phase of transmission or acquiring this infection and that surface antigen still isn't positive, you want to do a risk factor assessment. If any of those risk factors are positive, you typically will want to retest the mom for Hep B surface antigen. And again, if it's positive versus negative, it takes you kind of down this this algorithm, and part of that's counseling pregnant women about potential risk factors if they're not infected, and the infection risk factors that we're most concerned about are having a Hep B surface antigen infected partner, having a clinical picture of hepatitis that's being worked up, recent injection drug use, a history of sexually transmitted infections, or more than 2 sexual partners in the previous 6 months may put you in still a time period where theoretically your surface antigen may be negative, but you could be at risk of having the infection. Although typically, as we said in one of the earlier sessions, surface antigen becomes positive before the 6-month mark. So you'd hopefully pick that up. Okay, so this is kind of a handy thing for you to to refer back to. The CDC has funded nationally many states and cities to have what we call a perinatal hepatitis B coordinator system. So this is often really in conjunction with the public health departments locally and the hospitals. And the whole goal here is to make sure nobody slips through the cracks, that the mom who's infected gets referred for kind of chronic hepatitis B care postpartum, and that the infant or the newborn really receives appropriate prophylaxis if the mom is agreeable, and then followed further to make sure that they complete their vaccine series. All right, so let's say your hepatitis B surface antigen test result is not available. Then there's also an algorithm that's been developed by the CDC here. And again, this is all part of the CDC-funded perinatal hepatitis B prevention program coordinator. And there's a list of kind of coordinating sites and extra support we can give to our patients by having them connect with the coordinator from the public health department. So again, if the surface antigen status is unknown at the time of the infant's birth, let's say you're basically delivering that mom as they're walking in the door, which is not always an uncommon scenario, but one we typically like to avoid because we hope to have as many pregnant women engaged in medical care ahead of time, but that's not always the case. And so administering the first dose of the vaccine in HBV within 12 hours of birth or as soon as possible is an acceptable and recommended strategy if you don't know the mom's surface antigen and the baby is arriving as you're meeting them. And they also have kind of a weight-based algorithm in terms of the hepatitis B vaccine and the immunoglobulin administration. And then once the results do become available, which may not always be within the first 12 hours of birth, depending on the setting in which you're practicing, if you know the mom's status at that point, it's important to administer another dose of the vaccine 1 month after birth. Okay, so that's part of just the routine Hep B vaccine series. Let the pediatric provider know, refer the woman to the perinatal hepatitis B coordination program for case management if you're here in the United States. If they're negative, you still want to follow just the vaccination schedule to complete the series, and then make sure you're documenting everything in the chart. Obviously, the CDC, is stressing this because when they go back and they do surveillance, whether it be active or passive surveillance, they often are doing medical record chart reviews within health systems to try to enhance some of the records that get reported via the public health departments back to the CDC. And so if your baby is on the lower weight side, you will go with just giving the vaccine, checking the mom's surface antigen status, and then once you know the surface antigen status, you would administer the HBV a little bit later, and then still have the infant followed by the pediatric team. And then just really documenting the infant's immunization record. That is also used as part of the surveillance programs that the CDC and the local health departments are using. And it's not uncommon for hospitals, even big health systems, for example, where I work, for this to not be a perfect system, where not every single one of the surface antigen test results are getting reported, or the status of the infected moms and the newborns are not reported as well. So, we routinely work with our public health departments to try to optimize our procedures. Okay, so I think Chris was just responding to Jan's question in the chat, and I will get to it at the end. It's just a 2-log conversion factor that we'll talk about, the copies per ml versus the IUs. Okay, so this is kind of an overall nice infographic algorithm for you guys to refer back to for management of hepatitis B in pregnant women. So again, if the hallmark of the screening test in pregnancy is the surface antigen, and the surface antigen, if it's positive, tells you that the mom is infected with hepatitis B. We want to try to do some assessment of the hepatitis B stage and disease using additional blood work, imaging such as ultrasound. And then you want to really get a sense of, with these these tests, whether or not the mother has cirrhosis or advanced fibrosis. And if they do not have advanced fibrosis or cirrhosis, then you want to wait to test the Hep B DNA viral load between weeks 26 and 28. And if that Hep B DNA is greater than 200,000 IUs per ml, then you're going to initiate tenofovir therapy between really weeks 28 and 32. I think I said 30 to 32 is what we have in the guidances from AASLD. And then it is recommended to discontinue antivirals at the time of delivery or within 1 month postpartum. And the reason for this is that they have now done studies looking at women and preventing flares and improving outcomes with a longer course of antiviral therapy for up to 6 months or longer postpartum. And what they found was that there is actually no increased benefit with extending antiviral therapy postpartum beyond the time of delivery, or at least within one month postpartum. So that's why the AASLD and others recommend it's okay to stop the antivirals during that time. And after you discontinue any antiviral therapy, it's really important to monitor the ALT every 3 months for the first 6 months or after stopping antivirals. If the Hep B DNA is not above this 200,000 IUs per ml threshold, you're going to just resume routine Hep B monitoring postpartum like you would for those first 6 months, as we talked about, and then make sure that in any scenario, these women are referred for kind of chronic long-term management of their hepatitis B. Now, if somebody does have advanced fibrosis or cirrhosis, it's important to make sure you've determined whether or not they're taking tenofovir. If they already are, you want to continue tenofovir throughout pregnancy. If they're not, you want to make sure that they're not taking telbivudine or LAM, which again, they're not first-line agents in general for Hep B treatment. Sometimes we see people who are presenting for the first time coming from other places where they maybe have been managed for Hep B. So if they're not taking any other agent, you want to initiate tenofovir. If they are taking telbivudine or lamivudine, which is a pretty exceptional case, I would say, which you're not likely to see very often, you want to check the viral load. If the viral load is detectable, you want to switch them to tenofovir. That's already suggestive that they are resistant to one of those two agents and not having full great antiviral suppression, which is the goal of treatment. And then the plan would be, in the case if their Hep B DNA is not detected and they're on telbivudine or LAV, is to continue that throughout pregnancy and then consult with the hepatologist or GI doctor about whether or not to switch that patient post-pregnancy after they're out of the postpartum period. Okay, now kind of moving from Hep B and pregnancy, I wanted to talk a little bit about Hep B reactivation. So by definition, Hep B reactivation is a clinical syndrome characterized by sudden increase in Hep B replication due to a loss in immune control. So this is the standard definition for reactivation. What isn't very well standardized, unfortunately, when we talk about Hep B reactivation are the specific clinical parameters that define reactivation. So it's important to know that Hep B reactivation can occur clinically in somebody who is surface antigen positive and core antibody positive, or it can also happen in the scenario where somebody is surface antigen negative and isolated core and core antibody positive, and that's irrespective of knowing their surface antibody status. So anybody who's core antibody positive and or surface antigen positive is at risk, independent of knowing what the surface antibody is for reactivation. It can present as a wide clinical spectrum, as something silently that you might pick up by doing some liver tests. The patient's totally asymptomatic, and they're having reactivation if you look at their blood work. And then it can also present very severely in the form of fulminant hepatic failure. And it's very unfortunate, but at the place where I work, where we're a tertiary care medical center and we have a liver transplant program, we have at least usually one case a year of somebody in fulminant hepatic failure, just florid liver failure in the setting of Hep B reactivation. And it's most often because the provider who had been managing the patient either didn't know or check the status of the person prior to administering, immunotherapy or immunosuppressive drugs, and or the patient wasn't prophylaxed for a long enough period after or during immunosuppressive drug therapy. So this primarily occurs in this setting. It can rarely happen in other immunosuppressive kind of conditions. It's a pretty exceptional case. And lack of standardized criteria, as I just mentioned, is something that we're still struggling with in the field, but that we hope will be moving towards in the future in terms of how we really define reactivation. Is it an ALT greater than this level, or this many times upper limit of normal? Those kind of criteria haven't been very well established, although AASLD and others have established particular guidelines. They're just not always used in the studies that have been published. So the most recent AASLD guidelines in 2018 have defined Hep B reactivation as a rise in Hep B DNA from baseline, or absolute level of Hep B DNA when the baseline is not available. They also define it as reverse seroconversion, or what we call reversion. That's where you go from a surface antigen negative to a surface antigen positive for a patient who is core antibody positive. And then after Hep B reactivation, hepatitis flares, where then ALT elevation can occur. So the most likely thing, if you were to be actually monitoring a patient for reactivation, is you would see what we call the Hep B DNA rise first, and then usually the ALT, AST might go up later. Generally accepted criteria when you look at studies that have been published in this domain include the Hep B DNA increasing by greater than or 1 or 2 logs. Oftentimes some studies have included a high Hep B DNA cutoff if the ALT suddenly increases, and then detection of Hep B DNA or E antigen in somebody who was previously negative. And I think, sorry, I'm just trying to pull up my chat. Someone may have pulled up a question as we go. Okay, so Chris was just answering Jan's question, I think. Yes, it's never 1-to-1. It's typically a 2-log difference. So you have to, 1 IU equals 5.6 copies. So I think you gave an example of 500 IUs goes to about 2,500 copies. Okay. All right, going back to where we're at here, and we're happy to have a discussion more about the IU to copy conversion at the end. And then the ALT level greater than or equal to 2-fold increase above baseline and multiple upper limits of normal. AST elevations are not always present, so it's recommended that we monitor with the ALT. So you have what the AASLD has set forth in their 2018 criteria. You have kind of what's been published on the right in studies in terms of generally accepted criteria. Like I said, this is still somewhat of a gray area that we hope to have better defined now that we have criteria in place for studies going forward. So the risk of reactivation has to depend on a number of different factors that include host factors. So men, younger persons, having an elevated ALT before initiating immunosuppression, that's what IA stands for, having underlying other illnesses such as HIV infection, other chronic diseases such as kidney disease, end-stage kidney disease particularly, all can depress your immune system. So in that setting, we've seen certainly Hep B reactivation. It can also depend on viral and drug-related factors. So things that put patients at higher risk is having a higher Hep B DNA viral load in the blood. We know that people who are Hep B surface antigen positive or Hep B infected have a higher rate of reactivation than somebody who's just is surface antigen negative, but they may have the core antibody that's positive. And patients who are E antigen positive are also at higher risk for reactivation. And then people who have various mutations in the Hep B DNA may be at higher risk for reactivation. And people who have lower Hep B surface antibody, that should say titers, not titles, in patients with occult or resolved infection might put us at high risk, but we don't routinely screen for hepatitis B surface antibody titers as part of our management. And then various drugs increase your risk of reactivation. So certainly the intensity of the immunosuppression regimen, as described by the various toxicities related to the drugs, the duration of immunosuppression puts you at higher risk. Rituximab is kind of in a standout class all of its own, definitely puts both people who are surface antigen positive and those who are surface antigen negative but core antibody positive at higher risk for reactivation. High dose steroids also in some groups can increase risk. Anthracycline and then stem cell transplantation also seem to be higher risk of reactivation. So if you think about kind of drugs and how you should think about medications as they relate to your risk of reactivation, this is kind of a nice graphic that really goes over the degrees. So green kind of being a safer zone. You know, if you're not on any medicines, that's your best case scenario, but we know that we treat many patients these days for a number of immune mediated or of disorders or disorders that require immunosuppressive therapy. So this just kind of gives you in gradation, going from left to right, agents that increase your risk of reactivation over time. And you'll see that, you know, steroids and TNF inhibitors are kind of in this middle and then lower zone. Systemic chemotherapy by itself doesn't necessarily increase your risk, but we know that certain medicines, including B-cell depleting agents and stem cell and solid organ transplant recipients, are at the highest risk. Again, whether or not they're surface antigen or positive or surface antigen negative but core antibody positive, you can be at risk. So it's really important. The AASLD now recommends screening people for hepatitis B in the setting of immunosuppressive or cytotoxic drugs. So really all candidates for immunosuppressive, cytotoxic, or immune modulatory therapy should be tested for Hep B surface antigen and core antibody before immunosuppression therapy is begun. The presence of hepatitis B surface antibody does not prevent or protect you from Hep B reactivation. And as I mentioned, Hep B reactivation in the setting of anti-cancer therapies is anywhere from 41 to 53% in surface antigen positive and core antibody patients. But remember, reactivation can still occur in those surface antigen negative and core antibody patients, but at a lower rate of 8 to 18%, which is still pretty significant. And Hep B reactivation has been very, very well described in the setting of, most commonly, I think where the setting you're going to see it is in the setting of anti-rheumatic therapies with some of these TNF alpha inhibitor agents. And it can happen, again, at a higher rate in the surface antigen positive patients at 12.3% with these therapies compared to in surface antigen negative or core antibody positive patients at 1.7%. Now, the biggest thing I can't stress more than enough is that Hep B screening or testing rates are still very low in patients who are diagnosed with malignancies. It's as low as 19 to 55%. So we estimate that, you know, close to half or and up to maybe even 80% of people who are being initiated on immunosuppressive therapy are not getting appropriately screened. The one thing that has changed provider practices from not screening to screening, particularly in the oncological, rheumatological practices, has been an adverse outcome in a patient that they did not screen. So we want to try to avoid that. We don't want to wait to make a mistake on a patient by not appropriately screening them to change our behavior and our practice as providers. So it's really important that we're thinking about this up front and offering screening to anybody who's starting immunosuppressive or cytotoxic therapies. So in anybody who's surface antigen positive and core antibody positive, you would want to start Hep B prophylaxis before immunosuppressive or cytotoxic therapy, administer before at least simultaneous to immunosuppressive therapy, continue Hep B prophylaxis during immunosuppressive therapy, and for greater than 6 months after you stop. The one exception is anybody receiving those bigger gun therapies, the anti-CD20 therapies. You want to actually extend treatment for 12 months or longer. And I'll tell you that I, in the last year, saw actually, unfortunately, a patient who was appropriately screened, was taking, was diagnosed with a lymphoma, was receiving Rituxan-based therapy, was immunoprophylaxed until maybe a few months after they stopped therapy. And then therapy was discontinued, and he got admitted for a flare to our hospital and ended up passing away of fulminant hepatic failure. So this is a cause for why people die. And so it's really, really important that we're thinking about it. Anytime we're thinking about immunosuppressive drugs and cytotoxic drugs, screen them for hepatitis B. The recommended prophylaxis to prevent reactivation is entecavir, tenofovir, and TAF, for which we have data that they have really higher potency and higher resistance barrier. So you're less likely to develop resistance, and they act really fast at reducing your viral load so that you can initiate immunosuppressive therapy and cytotoxic therapies as soon as possible. In your surface antigen negative and core antibody patients should be carefully monitored with ALT and Hep B DNA, and surface antigen with the intent for on-demand therapy if you notice that those numbers start to go up. The only exception to this is any patient receiving anti-CD20 therapy, again, rituximab, or undergoing stem cell transplantation. So those patients across the board cannot be given a more conservative strategy of monitoring and then treatment on demand. But rather they need to have antiviral prophylaxis initiated at the time or optimally before they're starting an immunosuppressive therapy. And then for patients who are being monitored without prophylaxis, Hep B DNA levels should be obtained every 1 to 3 months. I'll tell you that's still not a perfect strategy, but this is what is recommended to try to pick up a flare or a rise in the DNA level, which would suggest reactivation. And then patients should be monitored for up to 12 months after stopping any Hep B therapy in this setting to make sure that they don't have flares or need chronic long-term therapy in the long run. All right, so I think we're going to kind of now try to move towards wrapping things up, but before we do, we wanted to talk a little bit, include one slide at least here on Delta infection. So you've often heard about, now we've talked about pregnancy, immunosuppressive therapy, Delta infections, another thing for providers to be aware about. So anytime you have somebody who's Hep B infected after you've screened them, the surface antigen's positive, it's important to also have some knowledge about Delta infection. Hepatitis Delta infection is actually a defective RNA virus that requires Hep B virus to be present in order for it to replicate. It has an incubation period of 5 to 64 days. And there's kind of 2 patterns of infection that it can follow. The first is superinfection, where somebody already has established chronic Hep B and then gets exposed to Delta virus in the setting of having chronic Hep B, and they develop acute Delta virus. This typically has a worse prognosis because the patient already has underlying liver disease from hepatitis B infection, and now you have another virus in the liver that's causing even more damage. And 80% will have chronic infection with both, and they can have a more severe disease. So it's actually not uncommon for people who have both of these viruses in the setting to develop signs of liver failure sooner, to develop cirrhosis in half the amount of time as if they had just Hep B infection alone. The other clinical scenario that you can see other than superinfection is co-infection. This is where you get acutely infected with both hepatitis B and Delta infection. And the thing I would really try to impress upon all the providers is to keep this at the back of your mind, particularly as you're seeing young patients or patients who have risk factors such as injection drug use, or recent sexual encounters. Also, we're seeing definitely more and more new cases of Hep B infection in younger individuals, not young enough that they got vaccinated as a child here, but still young enough that they're susceptible to Hep B infection, and it's because of shared routes of transmission. So we are seeing a rise in Hep B infection in some 30-some-year-olds, particularly as part of the opioid epidemic through injection drug use, and you're also at risk for Delta virus in this setting as well. In this co-infection clinical scenario, it's usually self-limiting, because what happens, again, as an adult, is you acquire Hep B infection, you're more likely to kick it out of your system because your immune system's robust, so your risk of developing chronic infection is quite low. It's 10 to 15%, but still significant. So in this setting, if you acquire both Hep B and Delta, your body as an adult can usually reject and get rid of the hepatitis B DNA for most people 8 out of 10 times, and the Delta virus can't really it's a defective RNA virus. So if the hepatitis B virus gets kicked out of your system, the Delta also does too. So this typically presents as a self-limiting biphasic ALT, and in less than 5% of cases develops chronic infection because your risk of hepatitis B infection is quite low chronically. Your risk factors for acquiring Delta infection, the most common ones you're likely to see are injection drug use and sometimes sexual. And it's diagnosed by sending a Delta antibody. You could also send an IgM and an RNA test, which are available through a CDC process. You can go to the CDC website. There's actually a form you can download. They give you instructions along with the clinical form to fill out how the sample needs to be collected and sent to the CDC to be run. And then if you were to do a liver biopsy, which as I mentioned, in some of the earlier sessions, which is quite rare, you could actually stain for Delta virus on the biopsy. Again, the clinical presentation can really run the range of self-limiting, asymptomatic to more severe chronic hepatitis, and unfortunately there are rarely fulminant hepatic failure cases. So, and anybody who comes in and we're diagnosing acute Hep B, we always, in a fulminant hepatic failure picture in the hospital, we typically are sending Delta serologies too. You kind of never get faulted for sending a Delta antibody. Most commonly it's going to come back negative. If that is positive, you can check some of these additional tests to see what has active detectable through the CDC testing process. The IgM is this, and then you're getting the it's usually pretty low rates of. The treatment for these patients is pegylated interferon alpha for 12 to 18 months, and then also therapies in some of these calls. I think Chris kind of addressed the, I actually never memorize it, but it's from, in terms of copies to the IUs. Now, Cade?
Absolutely. If you'd like different ways that you can let us know that you've got.
And did we address your question?
Yes, it's fine. Yeah, I just thought it just gets confusing. Yeah, I knew there was a conversion rate, something like 5. It just gets confusing when you're talking about the data on Hep B during pregnancy.
Yeah, so there is a conversion factor. I always just think of it as, basically like adding two more digits. That's the simplest way. The conversion, when you actually plug it into like a non-Young calculator, is going to be a little bit off from that. Generally, when you're in that range, and again, different laboratories will report it as copies per ml or IUs per ml. So it is important to try to convert it as much as possible if it's in copies to IUs in order to be able to use those algorithms very effectively.
Right. And, I did have a question about pregnancy. When you were saying that up to 15, 16% of transmission without for the higher, for over 8 million copies, which would be about 8 log, which would be 6 log for IUs. Was that in the setting of the infants getting HBV and vaccination?
Can you repeat that question one more time?
The question is, when you were giving the statistics of the percentage of infants of MTCT, a mother-to-child transmission, I think it was up to 18% for over 8 logs. Was that in the setting of the infant receiving HBV and vaccination?
Let me go back on my slides just so we can kind of reference. I think you may have been talking about, is it the table?
No,
here?
Yes.
Okay, so the question is, between the first and the second bullet points. Is that what
Yeah,
your question
are
is
those
about?
bullet points, is that perinatal transmission 9 to 15% in the setting of infants getting HBV and vaccination, or without it?
This is with without it, I believe. Let me just.
That's pretty low. That's low.
No, that's pretty low. So that's with it.
That's with it,
Sorry,
right.
that's with it. Because if you go back actually to the table here, it's more in line kind of with what you see here. So that
Right.
in E antigen positive, even independent of knowing
Right.
what the viral load is. So I was trying to show the data kind of in two different ways. So
Right.
E antigen confers a much higher risk positive than E antigen negative, even with vaccine and immunoglobulin therapy, which is the best therapy we have to reduce our risk. And then you also have kind of the risk factor of the viral level load.
Right.
And in that setting, you still have high rates. Yeah, and that's with, so we should clarify that, and we'll make a note. We'll add that to the slide.
And is the E antigen negative transmission rate so low? Is that independent of the viral load?
I don't think I'm following that. The
Okay,
E antigen
go back to that
transmission
chart.
rate?
If you go back to that chart you just had.
Yep.
So with the low rate of transmission from E antigen negative, is that because the E antigens having way lower viral loads? Is that independent of the viral load, or is that related to the low viral load?
It's probably related in some ways, but even independent of that viral load, we know that E antigen status increases your risk. So if you're so your question is, in the scenario of the E antigen negative, which we know is also associated with a lower Hep B DNA load, which one's playing how much of a role in terms of reducing your risk? Is that right?
Yes.
Yeah, so it's probably a combination of the two, but even independent, because you can still have a scenario where you have an E antigen negative mom with a high viral load. So they're independently risk factors, but probably in that setting, they also kind of dovetail together in a lot of scenarios where your E antigen is negative and your viral load is lower. But independent of the viral load being lower, you still have a lower rate.
And so the other question I had was that you showed that slide with the E antigen passing the placenta during gestation. When
this one?
Yes.
Yeah.
Yes. And does that cause does that cause infection?
So yes, you can less commonly get transmission of the virus during gestation, not at the time of delivery.
I mean, the E antigen causing
the E antigen's small enough. Yeah, the E antigen is an infectious still particle. So, so yes, you can. It's much less common. The vast majority of transmission happens here during delivery.
Right.
70+% happens at the time of delivery. We're not really testing babies in utero to do further studies kind of in this area, but we know that there is, based on some of the very old studies that have been done, there is some, when we do sample like cord blood and other things, that you see Hep B infection there.
So the reason I'm asking this is, since there's a lot of data about tenofovir because of HIV, like why do they wait? Do they wait to the third trimester because they just figure the risk during intrauterine is so low? But it also seems like it's so benign to give tenofovir during pregnancy, since all the HIV we have so much data on HIV.
So remember, tenofovir doesn't really, in this short time period of gestation, doesn't do much to your E antigen status. So it's not, remember, the goal of tenofovir is to reduce your risk, reduce your viral load, really, right? Because the hallmark of therapy is to suppress the virus and get it to undetectable or as low as possible. So the transmission during delivery really has to do with the Hep B DNA level being detectable, right? So we don't give it earlier in pregnancy, before the third trimester generally, with the exception of cirrhotics, in which we're trying to really keep the liver as stable as possible and not risk any decompensation in that setting. There is a lot more data in the HIV setting that, believe it or not, in the package inserts for HIV look different, look different than the indication for Hep B. Actually, when tenofovir was first approved, it was approved in actually a different dose that was used for HIV, because we had a lot of people who were dual infected with HIV and Hep B, so we had more data in that scenario. So it actually first got approved at a different dosing strategy than you had with Hep B mono-infected patients, until we built up more data that was submitted to the FDA. So yeah, we don't think, based on any of the studies that have been done, and Calvin Pan actually, who did this study along with Ram, the other co-faculty mentor for the series, Calvin has done a lot of research in this area and timing of antiviral initiation. And what they've ultimately shown is that earlier initiation of antiviral treatment before 28 weeks does not decrease your risk of mother-to-child transmission. That's been shown now. There's very good data in that area, so much so that the ASLD and even the European and Asian Pacific guidelines are pretty much in line with now starting antiviral treatment in the 3rd trimester. So does not confer, as much as you want to think about what it's doing to E antigen and the risk of transmission at that stage in pregnancy, based on even the randomized controlled data, does not lead to reduced risk of mother-to-child transmission starting it before 28 weeks.
Ponni, I believe we also have a raised hand from Dr. David Niam. Dr. David, did you have a question?
Yes, I just want to ask a question. Please, concerning the treatment for HBV infection, hepatitis D,
Okay.
either super infection or co-infection, in patients who have a background liver cirrhosis that interferon is contraindicated, is there another option, or those patients would not have any alternative to the treatment? And the other thing I want to say is the conversion for the copies per mil to international unit per mil. We get results in copies per mil and international unit per mil. So we use the factor of 5. We multiply international unit by 5 to get copies per mil. That is what we do here.
Let me look up the calculator again. And Chris, you looked it up, it looks like, while we were talking. Can you tell us what the conversion rate was, you said? So for 1 IU, you had 5.6 copies, but then you gave the example of 449 times 5, so it was a factor of 5, not 2?
It's actually a factor of 5.6.
Okay,
so, yeah,
so David, you're correct.
Yeah, you
Okay.
multiply by 5.6 to go to copies and divide by 5.6 to go the other way.
Yeah, I think, some labs certainly report both values, David, as you said, but not all labs do. So I think Jan's point was sometimes you only get the copies. Most of these algorithms are in the IU format. So I apologize about that. I think I was really, I kind of think of it as adding, up to 2 more zeros at the end clinically, and that takes you into the range of one versus the other. But okay, factor of 5. What was the first part of your question about Delta infection, though? I don't think
I was asking about the treatment. You mentioned interferon as the only treatment. So I was asking if there would be any option for patients who have decompensated cirrhosis in which interferon is contraindicated.
Honestly, at that stage, it's really questionable what you're trying to accomplish, I think, right? So we have given sometimes interferon in very low doses to decompensated cirrhotics. The scenario where we did this the most was actually with Hep C infection, but we occasionally saw some Delta infection, which we typically don't think is very safe. Your risk of developing bacterial peritonitis, other community-acquired infections are so much higher. Immunologically, Hep C infected patients are different than Hep B, but typically we don't have great therapies then for these decompensated Delta infected patients. How much do you see a lot of Delta infection in your practice, David?
No, we don't screen for the Delta infection. We don't screen for them.
Yeah.
We don't
Yeah.
routinely.
It's not recommended you give interferon to decompensated cirrhotics in this day and age now. Yeah.
Thank you very much.
Yep. Are there any other questions? I think we're over on time.
All right. Well, if there are no other questions at the moment, I will just launch the last couple of polling questions that we have for all of you. Just a few more here. This one should definitely look familiar. So we're asking, how confident are you now in managing hepatitis B in special populations, for example, pregnant women or those who are immunosuppressed? Keeping in mind that these answers may very well be different than how you felt before today's presentation. And I'll leave that up for another 5 to 10 seconds. Great, thank you for those responses. All right, looking back a little bit now, we want to kind of gauge your confidence about a different element of hepatitis B. So how confident are you now in interpreting hepatitis B serology? Do you feel not confident, slightly confident, moderately confident, or highly confident? All right, thank you all. And our very final polling question we have is rather a statement. I am able to manage hepatitis B infected women and immunosuppressed patients. Do you feel like you are never, rarely, sometimes, often, or always able to manage such patients? And I'll leave that up for a few seconds so everybody has a chance to interact with it. All right, thank you all very much for those responses. With that all being said, I've just placed a final sort of post-test and evaluation link in the general chat. Chris has also been sending you that message directly, so however you might want to interact with it, that's totally up to you. If you don't have time to access the post-test and evaluation today, we will be sending a follow-up email like all the other modules, which will include, again, the slideshow from today's lecture, as well as a link to that post-test. We will also be sending out video links of all of these sessions, so if you would like to watch them for your own education, feel free. You'll also have the slides to sort of supplement that. And the very last thing is, over the next couple of weeks, we'll be sending you sort of brief assessments and quizzes to sort of gauge where you stand, a little bit of time after the education. So just please keep your eyes peeled for that. We'll be sending them periodically over the next few weeks. With that all being said, I want to thank you all so much for attending ECHO Hepatitis B Bootcamp. We've really enjoyed presenting this education. We hope it was informative and helpful for you. And if you do continue to have any questions, even though the bootcamp is over, feel free to reach out. The mentor-mentee relationship does not have to end here. You can always also reach out to myself or Rachel as coordinators. And again, we'd really like to thank you all for your time, your engagement, your questions. I think it was a really helpful process. And so thank you all. Dr. Perumalswami, anything you want to close out with?
No, except for just to say that it's been a real pleasure getting to know all of you guys. Like I said, feel free to reach out if I can be of any help. I learned from some of you. I hope you learned from some of what we shared to you guys. And it was really nice to connect with all of you and just really be in touch. I'd be really happy to know kind of how your practices evolve over time, particularly with respect to Hep B after this.
Fantastic. Well, with that being said, thank you all so much again for your attendance and your engagement. And I guess we'll touch base soon. Keep an eye for an email.
Thank you so much, Dr. Ponni and Kate and Rachel. We had a very good time.
Absolutely. Thank you all for attending. We really appreciate it.